Hello and welcome to a new video from my channel. This channel is about CCI, chronic cervical instability. This video is going to be in English. My name is Uli Gottfried. I'm hosting this channel, and the aim of this channel is to increase the knowledge for CCI, especially in the German area. However, I know that there are requests already coming in to also do an English version of this channel. This is in planning, but right now still the focus is to talk with German doctors and to increase the knowledge here. However, of course, there is a huge knowledge in the United States. So for this reason, we will always frequently also talk to American specialists. And I always want to bring these videos also as a second version in the original language version. Yeah. On this channel, there is more than just the knowledge what's currently in the US. We touch also other topics like injury recall technique, which is also quite related to symptoms of chronic cervical instability. Also area of disturbance, especially in the tooth, mouth area, tonsillus. The CMD is a topic which is normally not touched in the US so far, at least on the channels. Actually, as far as I know, we are really the only independent global channel on CCI. All the other channels are more from doctors and then focus, of course, the treatment methods of those doctors. If you are German, I would really ask you to switch to the German version, as I will not only give a translation, but also more insights into the procedure interpretation, what Chris was figuring out in the first German part of a video. And the second part will be then the original video, where I'll also give you a hint how to turn on the auto translation of YouTube. So if you are non-German, then you can also look a little bit around my channel. There is the possibility also to switch on the auto translation and to pursue also a little bit of the contents. And I would also really highly appreciate your feedback about our content. And maybe this gives me the motivation to go ahead also with more English-based videos. So the procedure, Chris will introduce, or will I did a request for consultation at Chris Centeno Schulz. I think it's in Denver located, and this is exactly what the consultation was about. So if you're also interested in having a consultation, you should contact Chris directly or his assistants. In the United States, the cost is $280 US currently. This is 2023. And duration is 45 minutes. So you will present all the pictures, and he is then giving you the analysis, what you see right away. I wish you that this is beneficial for you, and hope that you will get sound and healthy soon, as you have some suffering right now. And twist the fingers for you. Thanks for popping in.
Oh, Uli, how you doing?
Hey, Chris, nice to meet you again. Yeah, good. Thank you.
Good to see you. So today we're looking at your neck, right?
Right. I have several diagnoses, and after our last call, I thought it would be a good opportunity that you have a look on this.
Yeah. So tell me what the current diagnoses are. Let's start there.
The first one was based on the upright MRI, dancing dance. That was not more defined. And then the second one was based on the upright MRI, which was 1.5 years ago, probably. That there was some kind of instability in the rotation to the right side, but on the new images, there is no instability visible at all. So it's a purely muscular problem.
Yeah, let's see. On the MRIs, I was looking at those earlier. This 2021 MRI showed a higher Grab Oaks. More interestingly is it looks like there's probably some deformity of the dens in that it looks like there's an osteophyte that's grown sort of along the apical ligament, in that the dens now touches the clivus or the basion here. So it looks to me like either the apical ligament or a portion of the tectorial membrane has become calcified. So that's, just could indicate long-term instability. On the rotational imaging from 2021, there's really not a large C1, C2 rotation. So that wouldn't meet the definition for instability. And that being more than 56 degrees based on a study by Dvorak. They tried to do, sort of simulate some open mouth, lateral bending views here. The corners of C1, C2 match up pretty well. Now, the problem with trying to do this in an MRI is that it probably has a high false negative rate, meaning that, there are C1, C2 lateral bending instabilities, or that type 2B, that it will be present that you won't pick up for two reasons. One is that you never really get the head over at a big angle. The other is that, digital motion X-ray is dynamic, and so you're going to see instability in a dynamic setting that you won't see in a static setting. So that's what's on there. There was some atrophy of the stabilizing muscles here at C2-3.
So it's pretty fat, I see.
Yeah.
Pretty wide.
And
so that's between C1 and C2, right? Where we right now?
C2-3. And that's normally where we would expect to see it. If there are issues, and then let's see here. It looks like there was some flexion extension imaging done here. So these aren't perfectly lined up, but it does look like there's some retrolisthesis here. And what I mean by that is that the C3 goes slightly backwards on the C4, and the C2 goes slightly backwards on the C3. There's a little bit of rotation happening with the vertebra, but it's not that bad. And so it looks like there's some minor amounts of retrolisthesis, meaning 2 going back slightly backwards on 3, 3 going slightly backwards on 4.
Okay, can you, the picture that you just marked, can you go up a little bit that we see the first vertebrae?
Sure.
Yeah, because here on the first vertebrae at the front side where the chin is, there is some kind of some up more up.
Yeah.
Here there is some kind of bone. So the expectation was that the dens is pushing to the front of the first vertebrae and making some kind of arthrosis. You see this?
Yes. There is osteoarthritis that's happening here at the atlantodental interspace with roughening and sclerosis of the bone surfaces. There's also an osteophyte happening down here and some other osteophytes happening up here.
So the expectation was that the dents is so that the ligaments are too strong and pushing the dents to the front.
Probably more likely that there's some element of instability that's been there for a long time, and then the body tries to put osteophytes or bone spurs there to stabilize that instability. And then it looks like there were some open mouth lateral bending views here. And again, they don't have you over very far.
Yeah.
But it looks like there's not much movement in that direction.
Yeah.
And we go the other direction. Not much motion there. So
now, Chris, the dominant problem that I have is that the head is slipping forwards. So, so if I do something bad, like wrong precision on the cushion, or strong tension of the muscles here, that the head is moving and then it needs to be rotated backwards. So for me, it looks like that there is some kind of instability between the head, the skull, and the C1. Yeah. If you look at the, you call it 1C, is there some visibility of some kind of flat
condyle there? Yeah. So here's what is interesting on these images. It looks like an extension. So let me get rid of a few of these to make this easier to see. So in extension, it looks like, so this is the condyle. And this is the atlas. So it looks like that the skull slips backwards in extension, and then in flexion, well, in flexion, it still looks like the condyle is backwards relative to the atlas here. As far as the amount or depth of the joint, it doesn't look like a flat condyle.
Okay.
But usually MRI is not the best way to take a look at that. That's better seen under or using a CT scan. You can see, you know, we're pushing the envelope with regard to the imaging on this MRI. So yeah, so based on what I'm seeing, I would say that there's certainly some evidence that there has been probably long-standing instability in the upper cervical spine. That's based on the extra osteophytes here that got added to the basion or the end of the clivus. Looks like that's either related to the apical dens ligament or to calcification of parts of the tectorial membrane. And same thing is seen over here in this MRI image. Now, if we were to do something like a PICL, that is a little bit problematic in that we can probably get below here, but we may be limited by these bone spurs on the bottom. It all depends on where those are with left and right of the dens. If there are none left and right of the dens, then we can get through. On the top, again, same thing. May be difficult to get through the bone spurs on the top to get into this area. We would just have to see based on what we're looking at there. But it feels like for you, when you flex forward is when you have the problems, and then you have to sort of push your skull back. Is that right?
Actually, right now, as I said, it's more the slipping of the head. When the head is slipping, I have the symptoms, and right now I can pretty normal move. Like I have restrictions from the muscular side, right? Like here, the musculars, but I don't have symptoms by moving right now. So I got a good improvement through the last 3 years, yeah, with all the things I did. So I cannot say, okay, when I look down, I get dizzy or something like this.
Okay. And then as far as your current symptoms, are they disabling or no? It's pretty good right now.
Now, as I said, it's a good improvement, and my wife is a medical doctor. She can put the head on the right spot again, and then after 5 minutes, the symptoms go down. Like it's symptoms of fear, sweating, heart rate variations. When I have this, I know that the head is not sitting properly. Yeah, then we do a test. She can test it by muscle tests, so kinesiology. And then, okay, then she does the manual adjustment of the head, and then it's fine again. And it works for the next 3 to 4 weeks, unless I do something bad, like I do something which is not good for me. Yeah. From the normal day, it's for me, it's a normal day. I mean, I have some muscular pain, but that's it.
Okay. And it sounds like you had some neck PRP injections. What did they do?
It's PRP, yes. They injected from the back blind PRP. They called it CD31 stem cells, but you would call it PRP.
Oh, okay. Yeah, there's probably not many.
It was like 12 injections. Yeah, but there was not a huge impact. Maybe not close by, let's say, maybe midterm after a year, but it cannot really correlate to the procedure, the improvement.
Gotcha. Yeah, so Yuli, I think there's some strong circumstantial evidence on the imaging that there has been instability at that skull base for a long time. And certainly your history of getting vagus nerve type symptoms, while atypical, is in the mix of the kind of symptoms that people can get with CCI, and also, helpful to know that your wife can relocate it and those symptoms go away.
Yeah.
So at this juncture, obviously, if you were here, we could get a digital motion X-ray to see if that adds anything to the imaging that you already have.
Okay.
And then it's a difficult decision for you with regard to, do you want to attempt something like a PICL procedure? Part of that is risk benefit, meaning that it sounds like things are manageable now. So do you pull the trigger on a more aggressive injection procedure versus the PRP that you already had and it didn't work? And then the other issue is always not only risk benefit, but also can we make it better than it is, and can we get where we need to go based on the bone spurs that are present on the imaging. So let me stop there and see if you have any questions that I can answer.
Yeah, actually, I mean, what I now recall is that the ligaments inside are affected, like the transverse, because of the grab oaks, right? The grab oaks would
Yeah,
indicate the transverse.
maybe. I mean, the difficulty with looking at the grab oaks and movement here is that it's difficult to tell where to place a grab oaks measurement. So for instance, we can see that the original basion was probably somewhere in there, but through the years, you grew this other part. So if we place this part of the grab oaks, we don't know where that goes. It should go at the end of the basion, but it looks like there is no end of the basion anymore. You could place it here or here. If we just stick with where
It is now.
where the calcification ends and put that there, and then we try to find the same place. There isn't a lot of change in grab oaks between the two. But again, that's made difficult by the fact that there's been calcification at the end of the basion, or the end of the clivus here. So I don't know that we can get a very accurate grab oaks as that measurement was designed.
Yeah, and if it's on the original point with not the grown part, then it would be okay or even worse.
Would be more.
Would be more, yeah.
Would be more. So if we go back to, let's see here, see if we can find.
I think the critical number is 9 millimeter, right?
Correct. So if we go back to this image and we try to find again a place to put that, we could call it here, which looks like the original, possibly the original end of the clivus. And if we chose that spot, then we'd have a grab oaks that's too high at around 11 millimeters. If we also looked at the clavoaxial angle there, assuming that's a correct placement, then we're at around 131 or so. So that's a lower clavoaxial angle, which doesn't seem to collapse in flexion, so that's good, and a higher grab oaks. But again, the problem is that if you place this here, which is the calcified part,
right?
Now the grab
it's okay.
becomes normal.
Actually, Chris, after your video, I did it by myself, and I said, okay, this is okay. But yeah. I mean, you did the video about the grab oaks, and I did the measurement. I said, okay, that's fine for me. But yeah, I didn't know that this growing part on the top.
Yeah, so that complicates it a bit because it becomes difficult to know.
Okay.
And we're comparing against studies where the basion was easily seen.
Yeah.
So anyway, that's what we're seeing there. But again, I think there's strong circumstantial evidence that there has been instability in this area because of the amount of bone spurring that you have here. Right. is not that common as it's presented.
Right.
Meaning that even in CCI patients that are your age, we generally don't see extensive bone spurring in this spot until patients get much, much older.
Yeah. Now, Chris, I said already, I did an analysis also on myself, and I think I must have problems since my childhood, where the head was then in the wrong position. So I did the body correction and so on. Last 10 years, it got worse, but I think I have it for quite a long time. Yeah, so that confirms my personal feeling, I would say. So coming to your terms of instability, it would be too B to A?
As far as classifying it right now, it could be a type 2A, that would be a high grab oaks. But again, depends on where you place that cursor.
Right.
So I would say most likely a 2A, but what you're describing with regard to the skull moving on the atlas, I think fits more of that type 1C.
1C.
So my sense would be what you're feeling looks more like type 1C, and we would need a DMX to get more information on that.
Okay. Okay. And the form of the vertebrae is not shallow, so the form is normal.
It looks normal.
Yeah, you said we need a CT. I know that's more precise, but your first indication would be that there is from the anatomical view is nothing really pops up.
Yeah, it doesn't look that abnormal, but it's not easy to tell on MRI. Sometimes they look one way on MRI, and then we get a CT scan and it looks completely different. So my sense is if we wanted to really dive into 1C, getting an upper cervical CT scan would be helpful. And we can write the order for that if you would like to get it. The only downside with the CT scan is it is a lot of radiation exposure.
Yeah. And what you have now identified is not seen on the X-ray pictures that I got lately, right? So you could not analyze this on the X-ray.
Very difficult to do because when you get up here, everything is overlapped, and so there's no way to really look at what's happening with the condyle. Now here, we do see some outlines of the condyle itself. And in just looking at the outlines of the overlapping shadows of the condyle, it looks like the condyle's got a pretty good curved shape and is not flat. But again, we're looking at multiple shadows superimposed on each other.
Yeah. Also, not the other types can be seen there. That's what I wanted to clarify. I mean, we discuss very, very often here. Okay, can you really see the things here on the upright MRI or on this X-ray images? So the best way it would be here, CT, but probably we would start with some digital motion X-ray first, right?
I think so, yeah. There is, again, as seen on this image, it looks like at C3-4 most convincingly, the C3 vertebra does go backwards on the C4 vertebra. And that's these two lines not matching up that well. This one's rotated a little bit, so we'll put the cursor in the middle. This one there. So 3-4 is going backwards slightly, or C3 on C4 here. I think we talked about that before.
Okay. So there is no indication on the facet joints. I know that the multifilus, I think it's the right name. They are not good, in not good shape.
Yeah, not great shape on the multifidus. And let's see if we can get a better image of that.
Yeah, now it's pretty obvious for me as well. It's
yeah,
like very white. Yeah.
Yeah.
What degree would you say is it?
I would say it's moderate atrophy of the upper cervical multifidus.
Moderate, okay. Yeah.
So that's here.
I think there is no image from the curve. Can you say something? Is the curve too straight?
Oh, the curve. Yeah. So the curve.
That's also.
Look at the neutral image here. If anything, there's more of a hyperlordosis than a kyphosis. So doesn't look too straight. So we have here a fairly big angle for, excuse me, the cervical lordosis,
Yeah.
then a kyphosis here. So what that means is that over time, and I think just with age, it looks like the upper thoracic spine has moved forward, and in response, the neck has increased its curve. And then what that does do, though, is that ends up putting the dens up top here in a retroflexed position. So, for instance, all things being equal, if we just look at the dens goes backwards here.
Yeah.
And then that puts that potentially puts more pressure on the cord here.
Right.
So if there wasn't as big a curve, the dens would be pulled away from the upper cervical spinal cord. So all this means is that, again, all things being equal, there's less room between the dens and the upper cervical spinal cord because of the hyperlordosis. If we didn't have a hyperlordosis, then the dens would be pulled away from the upper cervical cord.
Okay. Okay, that's also new for me because I got on the upright MRI report, I got the message that I have a slightly, well, that's in German, Streckfehlhaltung, like too straight. But you say it's too, the curve is too much, and this is because of the lower back is too stiff, or yeah.
So on the X-ray
Yeah.
from 2023,
Yeah.
And I'm assuming this MRI is upright, right? The 2021 MRI
Yeah,
was
it's upright. Yeah.
okay. So on the X-ray, it looks like there is some straightening. On the MRI, it's the opposite. There's actually
The X-ray was done like I needed to, I think, move the head like this, right? So it's automatic then straightened. Yeah.
Yeah. So
Also not absolutely clear, let's say like this. Yeah.
So if they instructed you to tuck your chin in for the X-ray, that would artificially straighten.
Yeah.
But on the MRI, there's a good curve here. If anything, like I said, the curve is a little bit high, and it's pushing the dens into retroflexion.
Okay.
That if we look at where what the dens would normally be, the dens would normally be in this orientation.
Yeah.
And your curve pushes it into retroflexion.
Yeah.
And again, all that's doing is that it's reducing the amount of space in front of the cord here.
Yeah. It would not explain why I have the symptoms when the head is slipping backwards, because then it would slip more far away from the dens tip.
So with regard to your symptoms, just to review again, your symptoms tend to get worse with the skull slipping backwards or forwards?
The adjustment needs to be done like this.
Down.
So I would assume it's slipping
backwards.
Yeah, backwards.
Back. Okay.
Forwards.
Yes.
Forwards. Back. Forwards, maybe forwards.
So you push it. You're pushing the skull into flexion, right?
I'm lying on a yeah, I'm lying, and then somebody is pushing my head like this.
Yeah, into flexion.
Yeah.
Yeah, that makes sense, because again, that fits with what we saw.
Yeah, that will make sense. That the problem is then the dens tip, which is fitting into the.
Yeah, so what you're describing is that the skull is probably slipping backwards, and then you're putting it into flexion here, or the skull is hyperextending. And realize that also could be due to ligament issues up front here. Because that would allow the skull to fall backwards. But I think we'll see a little bit more on the the DMX.
Yeah.
And
Yeah.
again, best for you to decide, is this something you want to undertake, or is your function good enough right now? And that's only a decision you can make.
Sure. Sure. I mean, I also need to review this video 10 times. Lot of content inside.
Yeah. And then just so that you know, when you're in extension, you have this buckling of the ligamentum flavum at a few spots, and
Yeah.
that's just the back part of the back ligament of the spinal canal that buckles a bit.
And this is because of instability of the third and fourth, second and fourth vertebrae.
Second and third, between the second and third, you have that, and between the fifth and sixth. And I think that's just degenerative instability that you probably have at those levels. And that's pretty common with aging.
Okay. Okay.
Other questions I can answer?
I think it's a new perspective.
Sure.
So there was a reason why I asked you.
So again, just to review, it looks like the skull tends to slide backwards. We don't know if that's necessarily due to a shallow C0, C1 joint. Can also be due to problems with the ligaments in the front. There is evidence of long-standing upper cervical instability because of the bone spurs in this area. And because of the bone spurs in this area, that may or may not block access for a PICL procedure. We'll have to see. And that getting a DMX would add information to the whole picture.
Okay.
And then finally, your decision as to whether or not you want to move forward with additional injections. And that's a personal decision based on the fact that you're higher functioning and that you have figured out how to manage this.
Everybody wants to be normal again.
I understand, and that's always a personal.
If I ask a lot of colleagues in my group, like they always say, "Oh, if I would be like you, it would be heaven for me." But for me, it's the next step. It's human being probably, but to go outside and have no fear, do maybe also exercises again would be, of course, the next step for me. And I want to do everything to progress. Yeah. So it looks like that a PICL method would be probably necessary, but we are not right sure whether it's possibly from the ankles here, from the ankles. Yeah.
From the bone spurs, yes. And
yeah.
So yes, I think it's something that we can certainly look at doing. We wouldn't really know until we got in there. Another way to determine that would be getting that CT scan, because that would give us more information about the status of the bone spurs, obviously also the status of the occipital condyle.
Yeah.
So if you'd like to get a CT scan there in Germany and send it to us, we can write a script for that.
If you have some address where we can go to for a motion, it's a motion CT, right? In function.
No, we don't necessarily need a moving CT, just the standard CT focused on this upper neck area.
So in function, like rotating or stable?
I don't think that we're going to get a lot of information out of the rotational component, and I think that's just going to add more radiation. So
okay, so just a simple one. Okay,
just a simple one.
Yeah, I was trying to get digital motion X-ray here because every bigger clinic has a DMX device, but also when you show them how the pictures should look like, how the movement should look like, I did not found any DMX, anybody who is offering this, even if you pay private. So in this case, I would really need to fly to you. Yeah, this is probably still the case. It's a pity. 300 meters from here, there is Siemens Healthineers. They produce the stuff. There's a showroom. When I go for lunch, I see it. I see the DMX device, but nobody is able to do it. It's a pity. I tell you, it's a pity.
Yes.
All right. So I think it's also from your side. I think what you wanted to say, I think you have said, right? There is nothing else to say from your side? I mean, we have analyzed the pictures, got some new content. Really thankful for that.
Yeah, and then obviously if you think of questions once you run this a couple times, then just send me an email and we'll go back and forth on the concepts.
Sure. Then thank you for your time, Chris.
Okay, thank you.